Hello, my name is Will Cook and I'm a student PTA at South College. Today I'll be going over the different amputation levels for the lower extremity. Basically, they're just named for where they occur. And the first one would be like a great toe amputation. And then you have like trans or any phalange. Then you have a transmetatarsal, which would be through the metatarsal bones. And then you have transtarsal, which would be through the tarsal bones. And then you have, moving on up, you would have a cymes. Sometimes the cymes retains the whole calcaneus and the heel pad, the fat pad of the heel, but it can also, moving up from the calcaneus, a cymes could be anything that includes the retention of the fat pad. Then you have ankle disarticulation, where they'll remove it right here. And then up on the transtibial, anywhere from the ankle up to the knee. And then a knee disarticulation, where they'll take the patella and retain the femur. Then transfemoral. And that is again anywhere from like a knee disarticulation up to a hip disarticulation, which is our next one, where they will just take the entire femur and leave the pelvis. And then there are hemipelvectomies, although we did not cover them in class, but they take part or all of the pelvis. And then we get on to a hemicorporectomy, which they're transecting at the lumbar levels of the spine, taking everything from here down. And that is extremely rare, but it is the most extreme type of amputation one can have. And it is likely due to like a very aggressive cancer of the pelvis or like a really, really bad infection. Speaking of, the reason for most of the other, unless it's like traumatic, I coached a kid in cross country who was struck by a car. And so he had a transtibial, actually on the scene, he had the car amputated his leg. But apart from that, most amputations come from peripheral vascular diseases, like arterial or venous insufficiency or peripheral neuropathy, like with diabetes. So like a patient could step on something and have no idea, then it gets infected, and the infection just spreads, and there's really no way to combat it. So, and also like with diabetes, blood sugar's high, it's feeding that bacteria, so it can be really aggressive. If there's like no viable tissue, there's no reason to try and retain that. You can, sadly, there's always a reason, but it's better, and there's better outcomes to just take it off. And I hear a child, so I'm gonna pause. Welcome back. For the sake of this video, Zara is going to be my transtibial amputation, and then Huxley has volunteered to be my transfemoral amputation. So for patient positioning purposes, we're going to have Huxley on his stomach to prevent hip flexion contractures. And then Zara, we're going to have her on her back with a towel roll or a pillow under the distal portion of her amputation to prevent knee flexion contractures. It's very comfortable to sit like this, have your patient like this, but that actually would promote a knee flexion and hip flexion contracture. So we want to avoid that. Also with Both of these, we want to avoid abduction contractures. So we don't want to be too flailed out like that as we are laying down. And that's it. This is Zara, and this is Huxley. Hello again. So we went over positioning, but for contractures, but we also want to cover a little bit about stretching to prevent contractures as well. So for that transtibial patient, we want to stretch the hamstrings, and we do this again to prevent that knee flexion contracture. Then, which makes it very difficult for fitting prostheses and for learning to walk with them. Then for the so hamstring stretch, just residual limb, definitely to focus on. Then we want to talk about the another thing to stretch with that, and this will also cover the transfemoral, but you want to stretch the hip abductors, because a hip abduction contracture also creates problems with gait and fitting. Then going into transfemoral, we want to do a hip flexor stretch, and we can do that on a mat or on the floor, as I am, and just getting those hips past neutral. You can go up prone on elbows, you can go up on hands, and again, this is just going to help prevent that hip flexion contracture that will make prosthesis fitting and gait learning very difficult.
No.
And the stretch for the abductors, again, it is like here. So you'd be with your residual limb stretching across. And then you really want to strengthen the adductors for transfemoral, because they attach down here. Hopefully there's been some, I mean, depending on the level where it is, there's some left, and that will, strengthening those will also help keep that leg in neutral and not just floating out here in rest. Next in the video, I will be covering a gait deviation, and the one I've chosen is called circumduction. So it's basically circumducting one of the limbs, or both of the limbs, I suppose. And this can happen because of weak hip flexors that aren't able to get the appropriate amount of hip clearance for the knee to bend and then clear the floor. Or it could be that their prosthetic is just too long. So that looks something like this. So step and then. So they bring it around because if they brought it through, it'd be like kicking the floor. And gait analysis for us as PTAs is important because we're like, what does Dr. Tomlinson always says? We're first line. So, we see something in gait, and we have to know why that could be and sort of address that, not sort of, but address that with our patients. So if their prosthetic is too short, we got to let our supervising PT know who makes their prosthetic and fits it for them. And then, work on different ways to avoid any weaknesses or contractures that the patient may have. Especially if they do have a too short or too long prosthesis. It's going to just be so much easier if everything fits and is in alignment. And last but not least, encouraging your patient to seek peer support for their prosthetic and like loss of limb and just the whole recovery process is invaluable. So like we as PTAs and like the therapy staff, hopefully, don't necessarily know firsthand what it's like to lose a limb and how to recover from that. So there are people out there that do. So encouraging your patient to seek out those resources like a group therapy or like a peer that has a similar amputation as them, and just like talking about their recovery process will help your patient lead to, or just have more faith in the process themselves, and like, hey, it gets better, and I'm living proof of that, which is a powerful thing. So yeah, thank you for watching.